Constipation is a common problem that we talk about extensively in GI clinic, but how it's evaluated may surprise you, and that's the topic of this video. By the time that you arrive in the GI clinic, your symptoms have built up and they're often layered by anxiety. So let's take some of that away and provide the reassurance that we think of constipation as a benign symptom, meaning it is not a red flag of cancer. Rarely people can have a mass grow and obstruct and suddenly cause a dramatic change in bowel habits, severe abdominal pain, constipation to the point that they aren't even really able to pass gas. And this is a distinctly different set of symptoms than the pattern that is typical of chronic constipation. Chronic constipation has already proven that this is not an alarming symptom. History is the most important factor to evaluate constipation. And while it would seem self-explanatory, really everybody has their own concept of what it means for them to be constipated. But the authorities have defined criteria for chronic idiopathic constipation and its bigger, meaner brother, irritable bowel syndrome constipation type. It starts with constipation that means that you have less than 3 spontaneous bowel movements a week. Next, it's that you've had persistent chronic symptoms, the better part of the last 6 months. Finally, there's the addition of pain that really becomes a qualifier for irritable bowel syndrome. There's some sort of impact that this has. It's not just simply that you're constipated, but you have bloating, you have straining, that you don't feel that you've completely evacuated. People may also at times have the sense that they've had some anal incontinence despite their efforts to go. These efforts to go can become quite extraordinary. Patients might feel like they're having to place themselves in yoga poses and become exhausted just to have a bowel movement, and they can also be distressing. People miss work because of their constipation, and some patients really even get to the point that they have suicidal thoughts because of the severity that's associated with it. Research would indicate that about 5% of patients meet these strict criteria for chronic idiopathic constipation and irritable bowel syndrome constipation type. We do see that there's about a 2-to-1 predominance of women, and that's probably because of the hormonal effects of menstruation, pregnancy, and the stress that is placed on the pelvic floor throughout carrying a child as well as delivering. So while definitions are useful for research, in practice, I find that most people that have arrived at my clinic certainly had significant distress of their symptoms whilst they have made the effort to be there, and they've probably also had a chronic problem because they suffered through it, went to their PCP, and now finally got an appointment with me. So if we're there together, then yes, you almost certainly have some form of severe constipation. However, we need to get down to the details of what's really bothering you. And this sometimes gets a little bit uncomfortable. It's not just about how many bowel movements you have, it's about what efforts have already been made to combat that so that we can get down towards a therapy, and also what's really bothering you. Because sometimes it's not really just the constipation. Actually, it's much more often about the sense of bloating, a sense of incomplete evacuation, and the difficulties, as I've alluded to. People practically get in yoga poses. We want to save that for the gym. Further, people sometimes have to get their hands dirty in order to get a bowel movement out, and that's very unpleasant. But don't find it unpleasant to talk about in the confines of a GI office, because I dare you to try to surprise us. Some people like to share pictures in clinic. No, not of their grandkids, but of their bowel movements. This is actually helpful. After all, a picture is worth 1,000 words. So if you've brought pictures, just go ahead and show us them. They won't really surprise us at all. However, we do not need a bag of poop to actually showcase the little boogers. We aren't going to be actually doing any stool studies, as that is more the realm of diarrhea, and the lab is happy to help you acquire a fresh sample. A primary care office will have often already excluded thyroid issues or red flags with basic blood work. For my part, I'll be evaluating the history of your constipation and focusing on the function of the colon and the rectum. Anal rectal manometry is a very effective way to see if there's pelvic floor dysfunction. It's a separate test that's performed that can measure the pressure in the rectum, the movements of it, your sensation to stimulus, and your ability to actually evacuate. There are other methods to also look at the transit of the colon. One of the older methods to do this is to swallow a capsule that has little radiopaque doodads that will then dissolve and follow their way through your colon. We take a series of pictures and we can follow their progress on that magical path. Depending on whether they end up spread throughout your colon very slowly, or do they all get stuck down in your rectum, gives some sense of whether the problem is more primary to the colon moving slowly, or is it that the rectum is having some mechanical issues with evacuation. Some centers have specialized MRI protocols that actually allow us to have a video MRI of the process of evacuating a bowel movement. This test is not too typically needed in the workup of constipation, but it is there when it's necessary. Soon I'll be discussing some of the medications that we can use for chronic constipation that go beyond the over-the-counter measures. So please subscribe to stay tuned for that. Until then, thank you and be safe.